My name is Laurent Macle. I'm an electrophysiologist at the Montreal Heart Institute in charge of the EP Fellowship program there. I will present to you the presentation is methods to identify the mechanisms and location of atrial tachycardias after AF ablation, and this is intended to be a practical approach as stated in a mini course we did on Wednesday. Usual mechanism of atrial tachycardia after AF ablation includes atrial tachycardia originating from the pulmonary veins or a macro reentrant circuit that can include a cavo-tricuspid isthmus-dependent circuit, a perimitral circuit, or a roof-dependent circuit. Finally, focal atrial tachycardia in the form of a through focal or localized reentry can also be found when encountering atrial tachycardia after AF ablation. The diagnostic approach to these tachycardia include the positioning of a decapolar CS catheter. This is important for three aspects. First, to evaluate the cycle length stability of the arrhythmia. The reason is if there's a variable cycle length more than 15%, then a focal site for the arrhythmia should be looked for. However, if there is a stable cycle length of the arrhythmia, then a macro reentrant or a focal source can be the diagnostic. Secondly, decapolar catheter can be used to assess the activation pattern of the posterior mitral annulus. If the sequence is distal to proximal, then the left atrial origin is most probably. However, if it's proximal to distal activation in the CS, then we should rule out the right atrial arrhythmia first. And if there is no cascade of activation on the CS catheter, a perimitral circuit is unlikely. Finally, this decapolar catheter can be used as a fixed atrial reference for the activation mapping. The first thing to exclude when mapping atrial tachycardia after AF ablation is a CTI-dependent reentry. This is done by activation mapping of the right atrium when starting the case, looking at the septal activation and the lateral wall of the right atrium activation. If it's compatible with either a counterclockwise or a clockwise flutter, this will be shown by either ascending septal activation and descending lateral activation or the opposite. In all these cases, the activation in the coronary sinus will be from proximal to distal. The entire cycle length of the tachycardia should be found around the tricuspid annulus, and in all cases it's important also to perform entrainment to confirm the mechanism of the arrhythmia. If the arrhythmia is from the cavo-tricuspid dependent, is a cavo-tricuspid dependent reentry, then the PPI minus tachycardia cycle length should be less than 20 milliseconds. This is an example of pitfalls of activation mapping alone, and that's why we need to perform entrainment after activation mapping. This is a case where a previous CTI ablation was performed, and you could see that there's a counterclockwise activation of the right atrium. However, when trying to confirm the arrhythmia by PPI performing pulse-pacing interval in the cavo-tricuspid isthmus, you can see that the return cycle length is 290 milliseconds for a tachycardia cycle length of 195, which is out of the circuit. However, when performing the PPI in the distal CS as shown in the right tracing here, you can see that the return cycle length is well within the 20 milliseconds. In fact, this was a case of a perimitral flutter, but the map on the right side looked like a typical counterclockwise flutter because of the previous isthmus line. This is to demonstrate that entrainment mapping should always be performed after activation mapping to confirm the mechanism. After having eliminated a CTI-dependent atrial tachycardia, the second step to look at is the pulmonary veins to see if there's a tachycardia originating from the pulmonary veins. In all these cases where reconduction from the pulmonary veins to the atrium is found, re-ablation of all veins should be done with the endpoint of complete electrical isolation. And this can be performed easily with circular mapping catheter. During PV-dependent atrial tachycardia, the activation mapping is showing that during the atrial tachycardia you have a distal to proximal activation of the vein, and during initiation of atrial tachycardia you would have a reversal of activation sequence, with first atrial signal followed by pulmonary vein potential during sinus rhythm, and during the first beat of the initiation of the arrhythmia, you would have the pulmonary vein potential first, followed by the atrial signal. If the vein is passive and during tachycardia, then you would have a proximal to distal activation. This is an example of a tachycardia that was originating from the right suprapulmonary vein, as seen on the right tracing here. You see a NAVIX image of that showing that the activation is coming from within the vein to outside the vein. Looking at the ablation catheter, which is standing here, you can see that the distal part is pointing towards the vein. And when you look at the recordings from that catheter, you can see that you have a distal to proximal activation, proving that that vein is responsible for that arrhythmia and is driving the tachycardia. In that case, re-isolation of that vein was successful to obtain sinus rhythm. The third thing to look for is a left atrial micro-reentrant. This micro-reentrant circuit can be either through the roof of the left atrium or around the mitral valve. Let's first look at roof-dependent tachycardia. In these cases, the activation mapping will show either the anterior wall of the left atrial will be ascending and the posterior wall will be descending, like in the picture shown here, when you have light blue going up to purple blue here, showing that the anterior wall is activated from bottom to top, and if you look on the posterior aspect of the left atrium, it's activated from top to bottom, which is consistent with a roof-dependent arrhythmia. In those cases, the activation in the coronary sinus and the anterior part of the mitral annulus could either be an absence of cascade of activation or a septal to lateral activation if it's a circuit around the right pulmonary veins, or lateral to a septal activation if it's a circuit around the left pulmonary veins. Please note that this makes no difference in the treatment because an ablation at the roof of the left atrium will cure both circuits. This is an example of activation mapping during a roof-dependent circuit. You can see that the ablation catheter was facing the anterior aspect of the left atrium, and the activation during this mapping is showing a proximal to distal activation, showing that the anterior part is activated from bottom to top. Please also note that on this coronary sinus sequence there is no cascade of activation, which is also compatible with the roof-dependent circuit. Looking now at the posterior wall of the left atrium, you can see with the catheter pointing down as shown on the left part of the screen that the activation is also going from proximal to distal on the catheter, so it's descending the posterior wall. So everything is consistent with a roof-dependent circuit. When mapping the roof with the ablation catheter as shown here, you can see that we could record a fractionated signal at that site, and performing PPI from that site, you have a return cycle length of 250 milliseconds for a tachycardia cycle length of 240, so 10 milliseconds, which is compatible with a roof-dependent circuit. Ablation at the roof was successful to obtain sinus rhythm in that case. The other potential circuit in the left atrium is around the perimitral annulus. The activation mapping in these cases would be consistent with the circumferential periannular activation, meaning that the posterior part of the mitral annulus would be activated lateral to septal, and the anterior part would be opposite, activated septal to lateral. There's an example shown here where you have the posterior part which is activated from lateral to septal, and the anterior aspect from septal to lateral. In cases of perimitral circuit, the activation of both the anterior and posterior wall will be from bottom to top, showing that it's also consistent with the perimitral circuit. This is an example of such cases where you have the activation on the coronary sinus that is proximal to distal. So we know that it's on the posterior mitral annulus, the activation is from septal to lateral, as shown here. And when we map the anterior aspect of the mitral annulus, this is in the anterior aspect here, you can see that we are 55 milliseconds after the reference at CS12. Pulling back the catheter more septally, as shown in this next slide, you can see that we get even later signals recorded on the ablation catheter, showing that the activation of the anterior wall of the mitral annulus is from lateral to septal, which is compatible with a perimitral counterclockwise flutter. So the posterior mitral annulus is activated septal to lateral, and the anterior mitral annulus is activated lateral to septal. In that cases, we could also observe that the anterior cycle length of the tachycardia was found around the mitral annulus. This is a NAVEX activation map of that arrhythmia, where you can see that the anterior part is from lateral to septal, and the posterior part is from septal to lateral, and that both the anterior aspect and posterior aspect of the left atrial wall are activated from bottom to top, which is also consistent with the perimitral flutter. After having eliminated the fact that it could be a CTI-dependent flutter, a PV origin for the tachycardia, and a left atrial macro reentry, the other potential macro reentrant circuit in the left atrium is a perimitral circuit. In these cases, the activation mapping will be consistent with a circumferential periannular activation around the annulus. The posterior mitral annulus can be activated from lateral to septal, and the anterior mitral annulus from septal to lateral, or the opposite. In both these possibility, there's an ascending activation on both the anterior and posterior wall, as shown on the NAVEX images here. This is an example of such cases where you see that there's a catheter and the decapolar catheter in the coronary sinus, for which the activation is from proximal to distal. Then we need to check for the activation in the anterior wall of the mitral annulus. Mapping the anterior mitral annulus here, you could see that the signal is plus 55 millisecond after CS12, taken as a fixed reference. You can also observe there's a distal to proximal activation on the ablation catheter, which would be consistent with an activation from lateral to septal. By redrawing this catheter more on the septal wall, on the septal aspect of the mitral annulus, you can see that the signal recorded is even later, showing that the activation in that case is from septal to lateral on the posterior aspect and lateral to septal in the anterior aspect. This is all consistent with a counterclockwise perimitral flutter, and also the anterior cycle length was found around the mitral annulus, and you can see that both the anterior wall and posterior wall of the left atrium were activated from bottom to top. Entrainment mapping was performed to confirm the mechanism, and this should be performed at two opposite segments. The first one was performed at the left mitral isthmus, as you can see on the left panel, and the return cycle length of the post-pacing interval was 255 for a tachycardia cycle length of 250, and the same was found when doing post-pacing interval on the septal aspect of the mitral annulus. This was then consistent with a counterclockwise perimitral flutter. This was successfully ablated at the left isthmus. The last possible diagnostic after having eliminated CTI-dependent arrhythmia, pulmonary vein tachycardia, and left atrial macro reentry is a focal atrial tachycardia. In these cases, a variable cycle length can be found. In cases where this is found, then the diagnostic of focal atrial tachycardia is most probable. But even if it's not a variable cycle length, it still could be a focal arrhythmia. There's two types of this arrhythmia. The first one is a true focal atrial tachycardia, like you could find in other substrate. It will represent a higher voltage electrogram, and it will cover less than 75% of the tachycardia cycle length. There's a special form of focal atrial tachycardia which is encountered after CFE ablation in the context of AF ablation. In those cases, a low voltage continuous activation will be found, and it will cover more than 3/4 of the tachycardia cycle length. The way to map these focal tachycardia is by activation mapping, where you could use the CS activation sequence to guide if the origin is more septal or lateral in the left atrium. These arrhythmia are more frequent in the left atrium than the right, but it's also possible. Then we map the area of earliest activation, and the activation is spreading radially from this area. Overdrive pacing can also be performed, and measurement of post-pacing interval can guide the site of arrhythmia. This is an example of such cases where you can see that there's a variable tachycardia cycle length of more than 15%. You can see that the mean cycle length of the tachycardia is 211 milliseconds, but it varies from 192 milliseconds to 220. So it's a variable cycle length. When mapping the left atrium in that case, we could find a localized reentry in the left atrial septum, just in front of the right inferior pulmonary vein. This is a case where extensive ablation was performed in the previous procedure, and at that site, sinus rhythm was obtained when ablation was performed. So in conclusion, when facing atrial tachycardia after AF ablation, we first have to consider the previous lesion set. Was there ablation performed? Linear ablation, pulmonary vein, were blocked demonstrated or not? Then, using a simple strategy based on a tachycardia cycle length stability and on activation, confirming then by entrainment mapping, we can arrive to a diagnostic. What we should look for is first eliminate a CTI-dependent reentry, then a PV-dependent atrial tachycardia. Then we have to look for a left atrial macro reentry either around the mitral annulus or via the roof of the left atrium, and finally, a focal atrial tachycardia should be mapped for. Thank you very much.
We can edit this.
Will you be able to edit, or do you want me to help you on that? Or?